Thank you, Michael. So we're going to take about 10 minutes for questions here so that we can move along in our agenda. But who would like to kick off with a first question for Megan or for Michael? We have the mics. Susan.
Thank you. This was a great panel. Susan Hull. I live up in northern Sonoma County. I'm also a nurse and an informaticist. My question is maybe to you, Michael, first, but also to Megan. It's exciting now that we've defined a set of social behavioral determinants of health that we want to have as a minimum data set in the electronic health record. And of course, it's an informatics challenge to think about that in a dynamic, real-time way with those measures and make them really meaningful for care for not only the provider, but more so for the patient, family, neighborhood. But what are your suggestions of how we approach that and even frame that effort so we can manage the technology needs of doing that, but begin to look at how care might be different because of having that information and making that information more transparent, not just in the episode of care, but, between care episodes in this more real, brick and mortar care, virtual care.
Okay.
Thoughts about framing it so that we're successful and, move it along forward.
Sure. Well, part of my response would be a matter of sort of education of the professionals and sort of a cultural shift, if you will, in terms of the expectations that professionals in defined healthcare roles currently have. So if you take what we're beginning to do at Dignity Health with our care management staff, care coordinator staff, and our community health staff, in many cases, those are individuals who did not know each other before. And the care manager may have access to and knowledge of some community resources, is certainly screening for some social determinants of health, even if they don't think about it in those terms, but may not have the same relationships with the community organizations and the community resources in the same way that our community health staff may have. So in our case, we're now building those relationships, sharing information. I had a regional care coordinator call me the other day asking for the community health needs assessments and implementation plans of a couple of our hospitals. So beginning to build that sort of awareness. I would imagine over the longer term, as we continue to talk about population health improvement, and that in and of itself is an educational journey that healthcare is on right now. As we deepen our understanding of that across more professional classes, there will be this awareness of the importance of the broader consideration of the factors that improve health, and then providing the tools, which are, I think, just now being built to provide the information you referred to, will be critical. And then the last thing I would say, in terms of pipeline, health professions education going forward, to the extent we can change those curricula to reflect these components, that would be important.
Great. We have a question over here.
Implications of hospitals driving population health out.
We can't hear.
So the fact that the hospitals are driving towards connecting people to social resources, but that those social resources just aren't there.
I think there's certainly are challenges in terms of resources not being present or present in sufficient quantity, if you will. But there's also a connectivity issue for sure, and a knowledge issue on the part of the healthcare providers. One of the ways in which some healthcare systems, and we're certainly not alone in this, there are others in the room that do this, seek to address that is by providing grants, is by making investments in the community with the resources we do have. I think there's also a key role for advocacy, and not only on the part of healthcare systems, but on others, for greater resources to be expended for support of community services. And one question in my mind going forward, as the model of healthcare delivery changes, as the models of payments change, as the definition of a continuum of care changes, what can we potentially wrap into reimbursable services in the future, years down the line. Now, we're going to need evidence to support the effectiveness of those things. We'll need data systems to support the management and coordination of that. But there may be, for some services, a little support there in the future as well.
Great. We have time for 2 more questions. We'll go here, and then if there's one last one.
You sort of walked, the G. McGuire from Northeastern University, you sort of, Michael, I'm here. I know, disembodied voices. You sort of walked yourself into the question I was going to ask, which is in the set of metrics that you've been thinking about that are informing your community health side as you build your continuum and its connection essentially to your operational population health management, on your enrollee side. What do you imagine are the metrics that are going to matter on that side that could inform investment strategies that are, and I don't mean to say not just community health benefits, they're certainly very important, but I think the assumption that maybe in value-based purchasing there'll be some headroom for investing in upstream efforts. So what metrics are going to matter over there, and how much is that, thinking about ROIs that have reasonable time horizons? So I don't know if your continuum has started to imagine that relationship to metrics.
Well, I would say that we've started to imagine it. I don't know that we've resolved it, or certainly do not have a metric set that we've said, here it is. One example that isn't specific to Dignity Health at all, there was recently a letter sent by some of the national hospital associations to the Internal Revenue Service and a meeting held specifically around encouraging that support of housing, of stable housing, be countable as community benefit for hospital reporting purposes, which is sort of inside baseball for hospitals. But the broader implication of that is, and the backing material for that was, there is a lot of evidence from much research that stable housing, if one has stable housing, a whole set of other issues begin to get resolved, and some of those issues relate to the ability to maintain health. So I would look for those places where there is evidence of a connection between a social condition, social environmental condition, and health status, and health-seeking behavior, healthcare-seeking behavior, and identify those. Asthma would be a great, is a great example, because we know what the environmental triggers are. We know that they're very place-specific and so on. And so putting investments there would make sense. I think looking for the evidence-based connections between those social determinants and healthcare use or cost.
Great. Any other questions in the room? We'll go here. Last one.
Thank you. I'm Veronica Shepard again. My question is to Megan. I was curious, it sounds like you were doing wonderful work with the violence prevention. I too live in an area where there's high violence in San Francisco. I'm curious to know, in regards to connecting this population to employment, were there pathways created for economic sustainability when they were getting jobs, and were there pathways of education and elevation? I find that a lot of times youth that go in and out of criminal justice systems, there's an institutionalized mentality, and yet they still need connections of role models, socialization skills, as well as sustainable employment opportunities. If they're going into $5 jobs, they're not coming out of the violence. So I was curious to know what mechanisms were put into place with your organization.
Great, thanks. So great question. The youth employment conundrum has a lot of layers. And so again, we found it wasn't just about creating more jobs, it was what you were saying. It's these youth in particular who we're talking about having access to those jobs and having the skills to be able to sustain a job, and the employers knowing what the best practices are for working with a youth. So some of the things that we put forward and are starting to progress in our communities, one is that we noticed that our summer youth employment program was only serving certain youth that had a certain GPA and met certain requirements. So how do we open up some of those programs to be able to include these other youth who really need the jobs that are in the neighborhoods that are most challenged, and that they themselves are the most challenged? So opening up some of those requirements and then making sure those supports are in place so that they are learning those skills and capacities they need to meet the demand of the employer. So we've got our Community Action Board, which is our local organization that does a lot of our employment work, and they're working to work with chambers to educate them, working with employers. They have a Jails to Jobs initiative where they're actually starting in juvenile hall and in our jails, connecting them to employers before they even get out, and then doing a lot of employer engagement. Alameda County has an amazing A Good Hire campaign where they're really working with employers to address their concerns, their legal concerns, their what if I hire someone with a record, what does that mean? And a lot of them are actual just myths that aren't at real legal concerns. So really digging down into what the employers need is another strategy we're using and moving forward with following the Alameda example. Those are just a couple, yeah.
Great. Well, please join me in thanking Megan and Michael for helping make this real.